Hello, and welcome to the oral poster session on the last one for the conference. My name's Karen Hutchinson. I'm a physio and researcher in Australia, and I'm very pleased to be chairing this session today. So each presenter will present for 5 minutes, and we'll have questions at the end, just because of the timing that it's quite a tight ship, I think. So I'm very pleased to introduce the first speaker today, who is Anne Buelens, on integrated childcare for young children with a disability.
Thank you for being here today, whether you're with us in person or tuning in from home. My name is Anne Buelens, and I'm a policy officer at the Flemish Agency for Persons with Disabilities. Today I'm quite excited to share our journey and the collaborative model we've been developed to support young children with severe multiple disabilities. Our core goal is simple, but yet crucial. We would like to ensure that all children, including those with complex needs, can grow, play, and learn alongside their peers in a supportive environment. Now, allow me to describe the current landscape in Flanders. This is illustrated in the figure at the top of our poster. So children under the age of 3 have access to childcare services through the Flemish Agency for Families and Children, also called Growing Up. The green triangle illustrates the various layers of support needed by each child in childcare. The bottom of the layers addresses every child's basic needs. The middle layer represents situations where children may need additional pedagogical support, such as language simulation or emotional safety within the group. The third layer involves support from specific experts. Sometimes the support provided by the first 2 layers of the green triangle may not be enough, and a child may require in-depth disability-specific expertise. This support can be provided through mobile guidance or outreach from facilities recognized by the Flemish Agency for Persons with Disabilities. The upper pink triangle focuses on children with highly intensive care needs that go beyond the capabilities of mobile support methods. This group includes children with severe multiple disabilities. Specifically for this group of children, we search for a method that is more inclusive and while we're ensuring the necessary care and support that can be provided. Now, how do we do that? We make the opposite movement. Instead of strengthening regular childcare for children with complex needs, we open the doors of specialized daycare. So the integrated childcare model brings together specialized daycare and general childcare services under one roof. This enables the recruitment of both general childcare workers and more specialized staff like nurses and paramedics. It breaks down barriers for parents to intensive support, and it fosters experience sharing among healthcare and childcare professionals because they're colleagues. Now, you might be wondering how this model looks in practice. You can find the model at the bottom of the poster. So the childcare organizer, in this situation it's Zorg Leuven, requires a license for 30 childcare places from agency Growing Up. The subsidizers will come from 2 agencies. Growing Up will subsidize 22 places for children, while the Flemish Agency for Persons with Disabilities will subsidize 8 places for children with severe care needs. Gansspoel, our healthcare provider, will oversee the organization and care of these 8 children. This ensures that the necessary support and care can be provided, allowing the children to grow up in an environment with their peers. Furthermore, there are some additional conditions that must be met for this model to be implemented in specialized daycare centers in Flanders. The infrastructure and the living group must be large enough to accommodate 30 children. There must be specific areas such as a tube feeding room or a storage place for adapted materials like keel walkers and standing frames. And in this particular project, there will as well be a sensory room. So, because of this specific need for adapted infrastructure, it means that the model cannot be implemented overnight. Now, let me point out one final additional advantage of this project between Zorg Leuven and Gansspoel. The building will also include residential care for the elderly and opportunities for partners such as the regional office of the Child Health Clinic. Now, I would like to take a moment to thank a few people, Kathleen Grovart from the agency Growing Up and Eline Degraeuwe from Gansspoel, because both of them has contributed to this poster but could not be here live. And last but not least, my colleagues from the Flemish Agency for Persons with Disabilities who are supporting me from home. Thank you for your attention and feel free to ask any questions.
Thank you very much. That sounds an absolutely wonderful programme. I forgot to mention, if you have any questions, you can add them to the app, and then that can be used at the end as well. So, sorry, I just have to get into my app again. And so, for the next presentation, we've got Angela Ryan, Optimising Healthcare Integration, Design Methodology, Approach to Developing an Integrated Care Service, Delivery Model for Irish Health Service Executives, Health Regions. Did I get that almost right?
Thank you. Hi, everybody. My name is Angela. I'm from the Health Regions Programme team with the Health Service Executive, or HSE, in Ireland. And this poster outlines the implementation of evidence-based design methodologies to develop an integrated service delivery, or ISD, model for the Irish Health Service Executive Health Regions. Sláinte Care is a 10-year programme transforming how healthcare in Ireland is delivered, building towards equal access to services based on need. As part of the Sláinte Care reforms, 6 HSE health regions have been established. These regional bodies are responsible for the planning and delivery of integrated health and social care services, empowering local decision-making and supporting population-based service planning. A key priority of the HSE health regions is to align hospital and community-based services to deliver joined-up integrated care closer to home. In creating the high-level design of integrated care services in the health regions, the programme team undertook a co-production process working with the Organisation Development and Design team and the Department of Health in Ireland. 94 individuals, including patient partners, HSE staff, managers, partner agencies, policymakers and integrated care experts, some of whom are on this stage during the last couple of days, collaborated in the design process. We implemented a co-design approach adhering to the evidence-based design methodology outlined in People's Needs, Defining Change, the Health Services Change Guide. This is our official policy for change within the Irish health and social care system. The approach was also based on the Public Service Design Principles, a component of Ireland's Action Plan for Designing Better Public Services. Throughout the co-design process, the IFIC 9 pillars of integrated care were also used to frame discussions. This design process was informed by the 3 phases of change activities within the Change Guide, which are define, design, deliver, as well as the 5 phases outlined in the Public Design Principles: empathise, define, ideate, prototype, iterate. The project team strategically integrated these frameworks, establishing a robust evidence base for this work. 3 integrated service delivery, or ISD, group events facilitated collaborative exploration of the Irish Health Service Design Challenge. Analysis of outputs identified patterns, defining user needs in line with the agreed principles. Key stakeholder groups participated in individual and small group meetings over a 6-month period to generate creative and solution-focused ISD options. Forums sought wider representation and feedback from GPs, academic officers, frontline staff, patient service user partners, and Chief Officer, Chief Executive Officer groups. These activities align with the engagement approach advocated in the Health Services Change Guide and the Public Service Design Principles. Workshops with frontline operational and clinical representation tested structures and evaluated ISD design assumptions, yielding 4 high-level structural options for integrated service delivery in the health service. The ISD workstream employed a multi-criteria analysis aligned with the European Commission Better Regulation Toolbox to identify preferences in terms of the preferred ISD model. This appraisal process resulted in an overwhelming preference for the high-level structural design depicted in this poster. This initiative serves as a guiding blueprint for navigating the design of an integrated service delivery model. By prioritizing systematic approaches, stakeholder collaboration, and human-centered design principles, our experience offers valuable insights for those tackling the complexities of integrated service delivery and structures to support its delivery. The engagement of diverse stakeholders, guided by co-production principles, highlights the significance of inclusivity in crafting solutions that resonate with unique community needs. This flexible, collaborative, and inclusive approach, in contrast to a formal and hierarchical one, aligns with the IFIC pillars of shared values and vision, people as partners in care, system-wide governance and leadership, and transparency of progress, results, and impact. Detailed design of the preferred model for integrated service delivery has commenced. This co-design process will adhere to the Health Service Change Guide, Public Service Design Principles, and incorporate the IFIC pillars of integrated care. Widespread stakeholder engagement will continue throughout the detailed design phase, facilitating the provision of the right care in the right place at the right time, as envisaged by Sláinte Care. I'd just like to acknowledge colleagues who were involved in this work, specifically Nuala Scannell, also from the Health Regions Programme team, who undertook this engagement with me throughout last year, and also the rest of our colleagues on the Health Regions Programme team, the Organisation Development and Design team, and all of our stakeholders who contributed with this throughout this extensive engagement, and hopefully we can continue to build on that in the future. Thank you.
Some great work going on in Ireland. Thank you very much. And so for now, for the next presenter, we've got Xiaoxu. Oh, sorry, my app decides to want to update Ding. On the feasibility and mHealth integration into integrated youth services, a secondary data analytics approach. Thank you.
Hi. So integrated youth service have emerged as a primary solution to address the mental health and substance use needs for youth through the creation of a seamless and coordinated system of care that address the diverse needs of youth across various domains of life. Foundry, which is the setting of this study, is an IYS initiative based in British Columbia in Canada. We aim to create a single access point for youth to come in and being able to access multiple areas and multiple kinds of services. Foundry also launched its virtual platform with a Foundry BC app during the pandemic to increase access, and they're being continuously used until today and in the future. For this study, we looked at a cohort of youth who accessed Foundry service from official app launch, which was around April 2020 to December last year, approximately across 4 years, with the goal to understand the service utilization pattern between virtual and in-person groups, to see the demographic and health profile differences among groups of youth who have different service access preferences. After looking at the data descriptively, we have three areas of major findings. The first one is among 41,034 youth who registered for Foundry, 25% of them never proceeded to access service. Around 40 of them only accessed in-person services, and around 17 of them accessed only virtual services, and the rest, 15%, chose to access both in a hybrid form. Looking at the virtual platform data where youth used to book and complete both in-person and virtual appointments, around 40% of youth who logged into that platform actually successfully booked an appointment. And out of the ones who booked appointments, only half of them proceed to complete those appointments. So if you give it an overall look, only around 20% of youth who accessed the virtual platform in the end completed an appointment. Our second finding is about the types of service accessed. The majority, so around 80% of virtual services visits were youth seeking help on, we call it My Feelings, but it is about stress, depression, and anxiety. And they count for around half of in-person visits, and close to 20% of in-person foundry visits were youth seeking help related to sexual health. Meanwhile, only 1% of youth who seek sexual services are doing this via virtual methods. Of course, we understand that some sexual health service involves testing and medications that is very hard to be delivered in a virtual setting. However, we still want to point out that the potential barrier exists for youth to seek help virtually for this type of service, potentially lack of safe space or trust on a virtual platform. Lastly, we found out that older youth between the age of 18 to 24 are much more likely to access virtual service compared to younger groups. Additionally, another significant difference is youth who prefer in-person services reported much better mental health status compared to youth who prefer virtual services. So to summarize, it is a very preliminary descriptive study to take a brief look at the service utilization pattern and the demographic health profile of the three groups of youth who chose to access RYS with different modalities: virtual only, in-person only, and a hybrid form. We learned that while these options are presented to youth, there are still barriers existed for youth to access and complete sessions. Future research is needed to understand the underlying rationale behind what is causing older youth or youth with poor mental health to choose virtual-only service. And with that goal, our ultimate goal is to improve service, even to look at the feasibility of personalized service, tailoring to the different needs in order to improve quality of care, health access, and the overall health outcome. Thank you.
Yeah, another great presentation there. That sounds like lots of options and trying to get different ways of engaging with young people. So now on to our next presenter, Felicien Izaturwanaho. I apologize for the pronunciation. Enhancing health inclusion services for homeless people towards trauma-informed e-case management system in acute care. Thank you.
Good afternoon, everyone, and welcome to this presentation. So you might have seen a little bit, some of the content has changed because this is your a PhD project. And so my name is Felicien Izaturwanaho, and thank you for pronouncing it. And I'm a PhD student in the Center for Innovative Human Systems at Trinity College, Dublin. And I would like to thank the Science Foundation Ireland Center for Research Training in Advanced Networks and Sustainable Societies for supporting this PhD project. And this PhD project focuses on understanding the needs of patients, staff, and organizations to trial HealthPass, which is a mobile health record app for inclusion health services to support people who are experiencing social exclusion, and those people could include those with lived experience of homelessness, drug abuse or use, and refugees. So this project builds on St. James's Hospital's efforts in addressing this issue using trauma-informed approach. So the study will involve like the use of mixed methods, because we want to try, and gain a deeper understanding of how health paths, can make a difference. So this PhD is divided into 4 phases, which are also aligned with 4 main objectives. So the first phase focuses on patient rounding in St. James's Hospital, which is the largest hospital, which is the largest teaching hospital in Ireland. And also it includes, meeting with healthcare professionals in Ireland to try and understand the health care system in Ireland. It also includes discussing with health paths developers to try and understand the app itself, and also it entails doing systematic literature review to understand, the evidence around the topic. So the second phase involves, the evaluation of healthcare utilization and also understanding user experience of health paths at Talacross University Hospital. And this will involve an analysis of quantitative data from an electronic health record, and also conducting semi-structured interviews with healthcare professionals. The third phase seeks to gain like a better insight into the user needs, patient, staff at St. James's Hospital, in conjunction with a community-based service provider. This also involves, the evaluation of the current usage of healthcare information systems, such as the electronic patient record. And in addition, we intend also to conduct interviews with patients and staff to understand their perspective on what would be, an ideal trauma-informed mental health, what would be like a trauma-informed mobile health record app for people who are experiencing social exclusion. So the fourth phase evaluates the healthcare utilization and also understand the user experience of health paths at St. James's Hospital in conjunction with a community-based service provider. And also here we'll analyze quantitative data from health paths, and also we'll conduct semi-structured interviews with patients and staff at St. James's Hospital. The final phase includes conducting focus group discussions with patients and the staff at St. James's Hospital to try, and define the research, and also formulate recommendations for how we could improve health paths. So, as you might have seen, so this PhD is like the expected outcome is threefold. Like we want to improve, integrated care or enhance integrated care. Like we want to reduce healthcare information fragmentation. I want also to try understand the needs of people who are experiencing social exclusion. Thank you.
That sounds a very interesting way of improving access to care and for people that are socially excluded at the moment. So it's really interesting. I'd like to know a little bit more. And so now we're on to our next speaker, introducing Taito Care to support clinical decision making for care home residents within the Southeastern Health and Social Care Trust. And we've got Robert Moore here. Thank you.
This is where I take my whistle wetler out of my mouth. Good afternoon, and as we say in Belfast, how's about you? In other words, how are you doing, and hope you're well. My name's Robert Moore. I am a technology-enabled care manager within the South Eastern Health and Social Care Trust, and I'm a registered nurse by background, but I have a role and interest in using technology that brings benefits to those in receipt of health and social care, but also to those who are delivering it. Just very quickly, the South Eastern Trust covers the other side of the river, outside Belfast, George Bell City Airport, down to the mountains of Mourne, so where the fields start to become green and it's not quite so built up. The Trust incorporates acute hospital services, community health and social services, and it serves a population of approximately 345,000 people. So the poster is really aspirational in that it gives an overview of the work that's currently underway and reflects a collaboration between the Trust, Taito Care and 30 care homes within our geography. And just to point out, the care homes are private, independent sector care homes. It brings with it an international dimension through the company and a uniqueness in that what we're currently doing is something that our trust is the only trust and organisation within the island of Ireland itself utilising Taito at this stage. So it's illustrative of us taking the leap to try something new and hopefully something that's exciting that will make a difference. The project is one of a number of responses from the Trust to recent winter pressures and involves our enhanced care at home and our hospital at home services in supporting care home staff to get more timely clinical interventions and hopefully reduce the need for potential hospital admission, which brings with it hospital transportation, emergency department attendance and so forth. And we know once an older person gets through the threshold of going into the hospital, they're going to be there for at least 5 to 7 days. So we're paying for the hospital side, we're also paying for the nursing home side. The project is very much around supporting care home staff in identifying and responding to the softer signs of deterioration with their residents, those early signs of infection that, if not picked up early in the day, could end up leading to delirium or sepsis, which often leads to hospital admission. And I suppose what I'm trying to say is this, quite simply: if we understand that know our residents well, they're not quite themselves, then we should be considering hospital at home or enhanced care at home services to have a conversation and to look at the way forward in managing that client, that patient. It's very much around using a medical device, a clinical communications tool for consultation and examination, whilst also connecting the clinical decision makers to provide alternatives to acute care. So what is Taito Care? I'm able to show it to people after the presentation, but it just comes in this little black box. But it is a mobile handheld examination device with multiple attachments that allow us to do multiple medical examinations anytime, anywhere. It allows for us to help with diagnosis, to give advice to the care home staff, and also for joint care planning in terms of can be given as a result of this. And it links together the individuals, the residents, the homes, the teams, the consultants, the GPs, and the families remotely. So when did we start our journey? Our journey was really started last year when we looked at our ED attendances and the homes that were sending folks up the road to the hospital. And we thought, well, can we actually work with these homes to do something to try and reduce the number of attendants? We contacted the homes following an introductory phone call, some backup information, and then I went out, seen the homes with the device, demonstrated it, and I got 30 homes signed up. And as the real world suggests, that's fine on paper, but sometimes a home closes, sometimes there's other things like viral infections, so sometimes the work got slowed down. So phase one, which was last year, was very much around getting the devices delivered, set up, getting our own cybersecurity issues sorted out and addressed, training of our own trust staff within the hospital at home team and the enhanced care at home team as users and trainers, and linking our homes with those services and building those relationships up. Because actually the use of Taito is very much dependent on referrals coming into the hospital at home and the enhanced care at home service. This year is very much about building up traction Getting the homes and the trust teams learning together, collaborating, blending the technology into clinical practice. This is being done by our teams in Hospital at Home and Enhanced Care at Home, along with our clinical nurse facilitators, who are providing both planned and ad hoc training to ensure that their homes are confident in using the device. And we're also sharing our training resources such as the Taito Academy. And also as clients or patients come onto the service, it's also a learning opportunity with the device and the home staff, as well as their own staff, to consolidate that. We're also having virtual question and answer sessions and monthly engagement meetings with the Trust and Care Home champions. And we really want our Taito champions to be the people who are going to continue promoting this resource. It's like everything else, technology. Sometimes it takes a while to bed in, and some staff are hesitant in the sense that they think it's replacing clinical care, and I'm going, no, I'm not doing that. I'm trying to enhance the clinical care and give the nursing staff and other clinical staff other ways of engaging, spreading our resources and giving timely interventions. So our suggested, 1 minute, okay. Early evidence would suggest that we can deliver acute clinical support remotely. We are enhancing the relationships between the trust and the care homes. We're hopefully enhancing the access and continuity of care, and also we're reducing the need for all contacts to be made by face-to-face. So our ambition and our key steps, apart from me hoping to come to Portugal next year with the results, would be to build up a body of evidence linked to the activity and the outcomes in using the Taito system. As we would expect, as the Hospital at Home numbers increase, we would envisage so would our use of remote consultations, undertaking and utilising the Taito device and trying to embed technology within our practice. And obviously we'll take a quality improvement perspective in PDSA cycles and so forth. Thank you for your time, and if anybody would like to have a look at the device after the session's over, I'll be here. Thank you.
Thank you. I'm sure we all want to see what's in that little black box. Now on to the next speaker. We've got Maeve Collins, who is talking on an integrated approach to improving the process for dietetic transfers from Acute to Cork Kerry Community Healthcare Dietetic Services. Thank you.
Thank you very much, and thanks to everyone for being here. So I suppose our initiative essentially looked at improving the transfer of appropriate patients out of the acute setting into primary care. So I'm a senior dietitian working in primary care since 2009. So it was amongst the dietitian transfer system. So we've all heard of Sláintecare. It has been mentioned throughout the conference. So the Sláintecare implementation plan again uses and focuses on the phrase getting the right care in the right place at the right time by the right team. So that's something we've heard over and over again for the patient, and it's a name that was underpinning, I suppose, our project. So to give a quick background, I joined the primary care dietitian team in 2009, and I got a post in Cork University Hospital in 2015. It was a part-time post, so I worked across both sites, both in primary care and in the main hospital. So I suppose it put me in a unique position to be able to view the issues on both sides. So traditionally, the patient transfer rates from the hospital out to community were low. We never really captured them across the whole lot of Cork Kerry community healthcare. I was able to find an old audit from 2017 based on a population of 175,000, which had a finding of about less than 3 patients per month. So if you were to extrapolate that up, it would have been less than 12 per month transferred out. So from a major acute hospital, this is a very low number. When I worked there, I saw why. The transfer forms were very long, very wieldy. It was a paper-based transfer system, a lot of duplication of information, transcribing of patient details, demographics, etc. It took 15 minutes or more to complete. whereas it took less than 30 seconds for me to write follow-up patient in 3 months in surgery outpatient clinic, even if that patient wasn't suitable or did not need to be coming into the acute setting. But at the end of the week, when you're already 2 hours late leaving, you can imagine which option was most appealing for clinicians. So I suppose outpatient clinics take clinicians off the ward, so really I knew it needed to be looked at as someone that worked on both sides. So during my time there, I worked on getting an IT system that was already in the hospital called ICM available in primary care. So this system, it proved very useful. It allowed us access to patient bloods, but when we wanted to set up a transfer system, it was the one we fell back on. We worked for a couple of years on setting up this transfer system, but COVID put an urgency on this. We needed to get patients now very urgently out of the hospital setting into community. So it actually very much expedited our project. We had all stakeholders on board at this stage. We had management who were behind us all the time. We now had IT on board. And I worked very closely with Gillian Holt, who supported me in this project in CUH, one of the other dietitians. So IT were able to generate a referral for us. This auto-populated all the patient details, the GP details, medical history, medication, and the whole discharge summary. So the dietitians really only needed to put in their therapeutic details. So I suppose just looking at results, we had a much more comprehensive discharge summary, so it was improving the quality of patient care because we had more information. A 50% reduction in time taken to complete the referral, and 50% was probably being pessimistic. It was a very high time, so it was saving clinician time. The information went into, it was a single route of referral access, so it was more traceable, accessible, so I suppose from a GDPR point of view, was more compliant. There was a reduction in OPD, the outpatient clinics, in the acute sector, therefore allowing dietitians to be on the wards, seeing the more complex patients. And the numbers of transfer rates out to community in 2020 were about 37 per month, up to 98 per month in 21. In 22 was 115, and last year was 146, and we're exceeding it again. So even last year alone, we had nearly 1,800 patients offered being able to be accessed an appointment in community, as opposed to having to travel 1.5 to 2 hours to an appointment in the hospital, battle with parking, etc. So I suppose overall, it's really about back to the right, the patient being seen in the right place at the right time by the right team. So thank you.
That's excellent and great to hear that people are getting care closer to home. And so now for our next presenter today, it's Lixia G. Assessing the effectiveness of an integrated primary and tertiary multidisciplinary diabetic foot care program, a historical control study. Thank you.
Thank you for the introduction. Hi, good afternoon, everyone. My name is Li Xia. I'm from National Healthcare Group. I'm a senior research analyst in Singapore. So, I'm so pleased to be here to present our evaluation work regarding the effectiveness of the diabetic foot in primary and secondary, in primary and tertiary sectors for the care of diabetes patients who have diabetic foot diseases. So we call this program Definite Care Program in short. So as many of you may know, Singapore has one of the highest diabetes-related lower extremity amputation rate in the world, with about 12.1 lower extremity amputation among every 100 Singaporeans in 2021, as compared to the average of 6.4 among the OECD countries. So you may see that actually the burden of diabetic foot diseases in Singapore is quite high. Hence, effective management of diabetic foot diseases is crucial for preserving patients' limb functions as well as alleviating their healthcare burden. So the definite care program has been implemented in 7 polyclinics, which is considered the primary care settings in Singapore, as well as 2 tertiary care settings. So this program involves about 60 healthcare providers who work together to provide integrated and coordinated care to the patients with diabetes foot diseases. So our study aimed to evaluate the effectiveness of the definite care program in terms of its effect on reducing lower extremity amputation rate, increasing amputation-free survival rates, as well as optimizing healthcare utilization. So we conducted an observational study with historical controls. So the intervention group comprised about 2,800 patients with diabetic foot diseases who were enrolled in the definite care program during June 2020 and June 2021. Then we select the historical control group who actually receiving treatments in any of national healthcare institutions during the time between June 2016 and December 2017. So all those patients actually have diabetic foot diseases treated during this time in our organizations. So we assessed 1-year minor and major lower extremity amputation rate, the mortality rate, as well as LEA, so-called amputation-free survival rates among the patients. Besides that, we also assessed the 1-year healthcare utilization in different care settings within National Healthcare Group. As there were significant differences in the demographics as well as the clinical factors between the intervention and the control group, which actually you can see in the table 1. So we decided to employ the propensity score matching to ensure the compatibility of the patients in both groups. So after the successful matching, we examined the treatment effect of the definite care program. And what we observed is the definite care group patients, right, they exhibited a 9% lower mortality rate, and also a 5% higher amputation-free survival rate. Additionally, those patients in the definite group also experienced about 1 fewer inpatient admissions and fewer ED visits. We also see that actually those patients had about 5.5 days shorter lengths of stay. However, the definite group patients had about 5% higher minor lower extremity amputation rates and more SOZ visits. So just to summarize our findings, our study actually suggests that the definite care programs has the potential impacts on increasing LEA, so-called amputation-free survival rates, and also transforming the care from the ED and inpatient settings to the outpatient settings. So moving forward, the program will be further expanded to more institutions, including GPs, and we are going to take a more preventive approach to extend the program to patients with moderate and high risk as well. So thank you for your attention. If you have any questions regarding the study, feel free to reach out to me. Thank you very much.
Another great presentation, and it sounds that there's less patients getting lost to follow-up. It sounds like they're being linked in a lot better and into the community. And so for our last speaker today, we've got Paudi McQuinn, the development and implementation of a community-based integrated care programme for older persons service in an Irish healthcare region, CKCH. Thank you.
Good afternoon. I hope you're all enjoying the conference. We just have the graveyard shift, so I hope we can keep you awake for another 5 minutes. My name is Paudi McQuinn. I'm project lead for integrated care program for older persons in Kerry. My background is physiotherapy, but I'm presenting on behalf of Cork Kerry Community Healthcare Older Persons Head of Service, the clinical operational leads, Dr. Bart Daly there, Dr. Richard List and Keith McGrath, and the operational leads in the Cork Kerry Integrated Care Programme for Older Persons. I'd also acknowledge the work of done nationally by the National Clinical Programme for Older Persons. General Manager for ICPOP, Sarah Shanahan, is back there as well, so doing some great work in promoting the Integrated Care Programme for Older Persons. For those of you not familiar with the area, Cork and Kerry is situated in the south west of Ireland, where we're rivals in the sporting context. We're allies in the delivery of healthcare in the area. We're famous for Cillian Murphy, Michael Fassbender, Murphy Stout and the Rose of Tralee. The area represents both an urban and remote rural areas. There's a population of 740,000, of which 15% are over 65, and there's a projected increase of 18% in 2028. Cork Kerry Community Healthcare ICPOP has recognised the need for age-attuned services as outlined in the National Clinical Programme. The ICPOP hubs that have been established, that have been developed, seek to improve the quality of life for older persons and their support networks by providing access to integrated care and support, which is specifically tailored to their needs and choices, thus supporting them to live well. The ultimate realisation will see a shift in care delivery from acute, episodic, reactive care to a coordinated and integrated model that is preventative, planned, delivered as close as possible to people's home environment. This is in keeping with Sláinte Care, the government's plan for delivery of healthcare in Ireland. So the project aims are specifically to provide a specialist geriatric medicine opinion using an MDT approach, multidisciplinary team approach, support the emergency departments, GPs, primary care, community health networks and the nursing home facilities to provide support and education to the older person, carers, their carers and other healthcare professionals. So some of the highlights, the establishment of 3 hubs within Cork Kerry, that's Cork City, 2 in Cork City, North and South, and there's 1 in Kerry. There's a number of high impact operational improvements that have been established within the hubs, so we're uniform in regards to policy, practice and metrics. We provide equity of access through a number of core and new additional pathways, for example, falls, frailty and memory, as well as nursing home outreach and nursing home support. We've integrated a number of existing services, for example, the frailty at the front door, a rapid access clinic and the community health network pathways as well. That's just making sure that all our pathways are end-to-end. Over 3,800 patients have been reviewed across all hubs in 2023, and the patient satisfaction audits that we've conducted have indicated 90% satisfaction with the audits conducted. A number of supports to live well, including the Community Connector Programme, memory gyms have also been established, as well as implementing the What Matters to Me. We've developed ICT shared folders, and we continue the rollout of the Interray project. We're participating in a lot of research and development, the Value Care project, which is the use of digital technology to support older persons. The Eclectic Framework, which develops interdisciplinary working, as well as the use of data analysis for a population-based approach. In regards to workforce capacity and capability, we've developed that through recruitment of age-attuned staff and ongoing training and development. So the future plans are the progression of more robust governance structures, the recruitment of vacant posts, progression of 2 further hubs in Cork, the progression of pathways with our acute and community health network colleagues, and embedding the research model, and most importantly, a theme that has kind of come across the whole conference for me anyway was improved service user involvement. We're also looking forward to the new REO and working with the new integrated health areas. So I suppose the key learnings from Scale Up were the critical importance of communication. Local relationships are invaluable. The effectiveness of the services may take time to manifest, and the governance pathways require ongoing development to meet the demands of an integrated system. So this poster reflects a programme still in its relative infancy. Significant progress has been made through cohesion of efforts across Cork Kerry Community Healthcare. And if I could just leave you with 2 quotes from some of our patients, it sums up what we're trying to achieve. "It meant everything to me. I was at home and I was able to say what I wanted. Life was happier. Thank you for the chats and laughs. Everyone deserves a voice. Thank you for helping me find mine. May you be proud of the work you do and the people you are and the difference you make." Thank you.
Thank you very much, and what fabulous feedback is that to have people's voices being heard. We've got less than 10 minutes, and I just wondered if there are any questions at all for the speakers. No? Well, I've got a couple of questions. I was just wondering, so I'll just have to try and find my different presentations, but I was just wondering, because there wasn't much talk about who funds some of these, or how the funding works across all the integrated care, and I thought that would maybe be something to ask the different speakers. So I wondered if we could maybe start with Anne. Is Anne still here? About the different, who funds the programme in the childcare centres.
Just talk like this.
Is there a microphone
It's 2 kinds of fundings. The first one is from the agency of the families and the children, and they fund just the regular childcare facilities. And then up to that, when there is a child with a specific need, there can be a funding from the Flemish Agency for Persons with Disabilities to have mobile guidance and those things. And then you've got a separate thing that if the care is such high that mobile guidance isn't enough, then you can go by the funding of the Flemish Agency for Persons with Disabilities for all. But the thing is that the funding is 2 ways, but the house or the place where the care will be presented is one place. And I think that's the most important, that the funding, it doesn't matter from where it's coming, but for the people in the house, it's just one place where they go to and they get their care over there, and they don't mind from where the funding comes. But
yes, but the funding is for the person.
Yeah.
Yes. Okay, that sounds fantastic. Anybody else want to talk about some of their funding, how their programs have been funded at all?
Thank you. My PhD is funded by SFI, which is Science Foundation Ireland Center for Research Training in Advanced Networks and Sustainable Societies. And I'm doing it at Center for Innovative Human Systems in Trinity, Dublin College. But also I do that in conjunction with like a patient, observing patient round in St. James's Hospital. So it's, which is also like a teaching hospital that works closely with the Trinity Dublin College. Thank you.
Yeah, and while you've got the mic, can you, health pass that you talked about, is that an app, or is that how does that technology work?
Yeah, basically it's like a mobile health record app. Yes, it's an app. Like you want to enable patients to have access to their health records on their mobile phones. Yeah, so yes, it's an app.
Okay, thank you. And is there anybody else? I mean, Paudi, if you have any?
I suppose it's the European Community Care Programme in Ireland, of which a number of different national clinical programmes are rolled out. So we fall under the National Clinical Programme for Older Persons, and then there's also a National Clinical Programme for Chronic Disease, of which there's been presentations throughout the week. It's also the community health networks as well, so there's kind of, it's the health services going under a bit of change as well, so there's a lot more investment in kind of those integrated pathways where that's where the funding is coming from, so those kind of specialist teams targeting specialist areas, yeah.
Excellent, thank you. And any of the other speakers want to sort of add anything about funding? Nobody's wanting to volunteer? Is there anybody else got any questions at all, just after me asking a few more? No? Well, I think we'll probably wrap up the session today, and thank you very much again to all the speakers for taking the time to sort of do a 5-minute presentation on a very detailed posters. So thank you again.